the world, and so this is the first of the GUPS educational sessions that we are offering, and I'm very excited to be chairing with Santosh this session on penis, a topic which is often not well covered, and we don't seem to see as many cases, so people will often have a lot of questions and not a lot of experience. So we've got 3 very experienced pathologists who are kindly going to share their experience with us to help us learn and understand penis more. So take it away, Santosh.
Thank you, Samson. Thank you, Gups, and thank you, Fiona, for having me here. We have 3 topics lined up. To start off the proceedings, I would like to invite Dr. Judy Sarangam from the MSKCC, New York. Just to introduce Judy briefly, she's an assistant attending pathologist at MSKCC, where she did her oncology surgical pathology fellowship, followed by a genitourinary fellowship, after having done her basic medical schooling in India. So she's ardently interested in penile and urothelial cancers. And Judy, with that, I would like to welcome you to present your topic on cut-up and grossing of penile lesions.
Thank you so much for the introduction, Santosh. So let me share my screen. Can you see the presentation?
Yes.
So good morning and good evening to everyone. So I'll be talking today on handling and staging of penile tumors. These are my disclosures. So before we discuss the topic of this session, I would like to talk on the anatomy of the penile penis, as it is very important when we handle the specimen and for staging the tumors. As you know, the penis has 2 main parts, the distal penis, and which is composed of the glans, the coronal sulcus, and the foreskin, and the shaft of the penis. These are the 2 main portions of the anatomy of the penis. The glans is composed. The bulk of the glans is composed of the corpus spongiosum, and as you can see in this picture, and then it has 5 layers: the epithelium, the lamina propria, the corpus spongiosum, and then we have the tunica albuginea and a portion of the corpora cavernosa. And then we have a special skin fold, which is called the foreskin. It has a mucosal surface on the inside and skin on the outside. This is the histologic section of the foreskin. The mucosal surface is the non-keratinizing squamous epithelium. The lamina propria, we have the dartos muscle in between, and the subepithelium of the skin, and then the keratinizing squamous epithelium on the outer surface. The coronal sulcus, as on the other hand, has only 3 layers, which is the epithelium, the lamina propria, and the fascia. Now coming on to the shaft of the penis, the main bulk of the penile shaft is composed of 3 cylindrical masses, which is the erectile tissue, the 2 corpora cavernosa, and the corpus spongiosum with the central urethra ventrally. We have a dorsal vein on the posterior aspect. The corpora, they are covered by a thick tunica albuginea, and then this divides the corpus cavernosum into 2 portions. Outside of the tunica albuginea is the buccal fascia, which is just a loose hypovascular soft tissue, and then this outside of this buccal fascia is the dartos muscle, which is composed of this continuous layer of smooth muscle. And finally, we have the skin. This is a cut section of the shaft of the penis, as we see from one of our grossing specimen. We can recognize the corpus cavernosum, the urethra with the corpus spongiosum, and the dorsal vein here. So now coming on to the real topic, how to handle the penile carcinoma specimens. First, it is important to know the different type of specimen that we can receive in pathology. So we can receive circumcision, glans resurfacing, glancectomy, which can be partial or complete, and penectomy, which can be partial or total. So circumcision is sometimes used to treat in situ and small lamina propria invasive T1 lesions situated on the foreskin, and these lesions may also extend to the coronal sulcus. Those are also treated with circumcision specimen. When we receive these specimens, they are usually not very complicated. For any grossing specimen, we recognize the skin surface and the mucosal surface. And then on the we measure the specimen. Any lesions are identified, and then we measure them again, and then distance from the lesion from the margin is also noted. Then we ink the mucosal, resection margin. The mucosal surface and the skin margin is inked differentially too, so that it's easy to recognize on the under the scope. Then after having done this, we stretch and pin it on a carpet to flatten it, and then fix it for several hours, and then serially section the specimen, and then submit it for entirely. Glans resurfacing is another procedure of which is an organ sparing surgery done for penile tumors, and they are usually done for early stage in situ or early stage penile carcinomas. It was first described by De Pascal et al., and when it was first described, it was done for severe lichen sclerosis, and in this procedure involves removal of the epithelium and the subepithelial layer of the glands, and this may also include a little bit of corpus spongiosum, and that defect is covered by the skin graft. So in this procedure, the surgeon make a quadrant cut from the meatus into the coronal sulcus, and then they separate out the epithelium and the subepithelium, exposing the corpus spongiosum. This is a pictographic representation, and in the pathology department, what we get is a specimen looking like this, which may be, again, it may not be in one piece, maybe in two piece. But important thing is what we need to recognize is the margin. We have one peripheral margin and a deep margin. So those are inked differentially, and again, we identify any tumor or lesions, and then describe it, and then submit it in entirety. But nowadays, don't be surprised that if you don't receive this specimen in the in pathology, because they do these gland resurfacing using ablative laser. So we don't get these specimens often in the in pathology. So glancectomy is another organ sparing surgery used for treating early stage penile carcinomas. It can be partial or complete depending on the size and location of the tumor. During this process, surgeon remove a portion of the glands or entirely the glands. The mucosa with the corpus spongiosum is removed, and this may also include a little bit of a tunica albuginea. Again, this is usually not a very complicated specimen. We need to identify the margin. Most of the time they are not oriented specimens, so I didn't just identify the deep margin, ink it, serially section, and then submit in entirety. But sometimes we do get oriented specimen, for example in this specimen that is pictured in this photograph here. Finally, coming to the penectomy specimen, which can be partial or total. For any specimen, we identify the specimen, take measurements, and identify the parts of the organs that was received. Does that include the glands? If there is a foreskin, note the presence of the foreskin, and describe the foreskin. Foreskin can be long, medium, or short, depending on how the coverage of the glands is by the foreskin. Identify any tumor or lesions that is on the specimen, and then and first thing we do is take the section of the margin, because that is something we do it before we go any further with the specimen. The margin sections are taken en face. So what are the resection margins? The main component of the resection margin are the urethra and the periurethral tissue, which is depicted here, and it includes the urethra, the corpus spongiosum, and portion of the tunica. Many a times, the urethra is retracted, so you have to identify them, pull it out, and then take a section and submit on fast in entirety. The rest of the section margin, which is the proximal shaft or the composed of the corpus cavernosum and the skin and underlying soft tissue, they are taken also on fast and submit entirety. If everything is not fitting on the cassette, it can be done in multiple cassettes. It has been shown that the most common positive margin is seen around the urethra and the periurethral tissue. This is a pictographic representation of this gross specimen where there is tumor involvement of the urethra and the periurethral corpus spongiosum actually here, and then the pictographic representation here, and a histologic finding of the squamous mucosa involving the urethra. So after taking the margin section, the specimen is fixed for several hours, and there are two ways you can process this specimen. One way is the one depicted here. So we identify the urethral meatus and the proximal urethra, and then bisect the penis into two halves. And then you can leave the foreskin if it is bulky, because you can appreciate the relationship of the tumor to the foreskin. This is one half of the bisected penis from this, and then you can see tumor involvement of the glands, the urethra, and even the corpus cavernosum. And then once we have this, we can serially section into multiple smaller pieces and then submit entirely. This one is a total penectomy where there is more of the shaft and the glands. And then we have another representation here, which is just the glands and a little bit of the shaft. The tumor is located in the glands and also involves the coronal sulcus and the foreskin. Another way we can process this specimen is transverse sectioning the penis and then submitting at the whole mount sections. This is after taking the margin sections, the penis is fixed for several hours and then serially sectioned from proximal to distal, and this is the corresponding serial section of this penectomy specimen. We can see this is the most distal portion. We can see that edge of urethral meatus with the tumor. As we go more proximally, we start noticing the corpus spongiosum. And then as we go more furthermore, there is the corpus cavernosum and the penile urethra here. And the tumor can be seen involving the corpus spongiosum. So this is a corresponding H&E section of the one I just showed you, and it is easier to recognize. It is very easy to recognize the anatomy of the penis when we do this, but this may not be feasible for all labs because many places do not do whole mount sections. So finally, coming to the main topic, another second part of the topic is the staging of the penile carcinoma. Staging is based on the level of invasion, the grade of the tumor, the perineural invasion, and lymphovascular invasion. And they are, this is according to the AJCC 8 edition. It is PTS or PTA, then PT1, which is subdivided into PT1A and 1B, then PT2, 3, and 4. This I'll be talking a little bit about all of these subsequently with examples. Lymph node staging is based on number, the location, and extranodal extension of the metastatic focus. So there were a few changes from in the AJCC 8 edition from the AJCC 7th edition, which I wanted to highlight. First one is the TA, which was initially called the non-invasive verrucous carcinoma, is now called non-invasive localized squamous cell carcinoma. Another thing is perineural invasion is now included in substaging of the PT1 tumors. The urethral involvement, which was initially part of PT3 in AJCC 7th edition, is no longer in the 8th edition. And the PT2, which was called the corpus spongiosum and cavernosum involvement in 7th edition, is now now divided into corpus PT2, which invades corpus spongiosum with or without urethral invasion, and PT3, which invades corpus cavernosum with or without urethral involvement. These are the these are the changes in the AJCC 8th edition. So these are some examples of the different stages of penile the tumors. So this is a tumor with representation of a carcinoma in situ, also known as the penile intraepithelial neoplasia. So this is a tumor which is limited to the surface. This one is an example of a basaloid or HPV associated penile intraepithelial neoplasia. And these other two are non-HPV associated penile intraepithelial neoplasia, or the now also called differentiated penile intraepithelial neoplasia. Their atypia is just limited on the surface mucosa, and there is no invasion into the lamina propria, and they are most of the time flat lesions. PTA tumor has a more exophytic growth pattern and is bulkier and visible clinically. It can be non-invasive and growing above the level of the basal layer, or it can be it also includes these invasive tumors with the broad pushing front. These has to be very smooth outline. There should not be infiltrative edges in this lesions. They don't include just verrucous carcinoma, but also includes other subtypes, for example, basaloid, warty, papillary, and mixed subtypes, but all with a pushing front. Here are some representation of the PTA tumors. PT1 tumors are divided into PT1A and 1B tumors. They are lamina propria invasive tumors, but based on the presence of lymphovascular invasion, perineural invasion, or poorly differentiated or grade 3 or sarcomatoid areas, they are subdivided into PT1A and 1B. Those with features that one of the features that I have described is are called PT1B, and those without are called PT1A. So I have a representation of PT1A tumor here. This is a gross specimen of partial penectomy. We have the glands, the urethra, and the foreskin, and the tumor can be seen here in the glands mucosa. This form white lesion. And this is the corresponding representation of the same area. We can see this invasive tumor involving the lamina propria without involving the corpus spongiosum. This is the foreskin. And high power view of the lamina propria invasive squamous cell carcinoma. Many studies have shown that histologic grade, perineural invasion, lymphovascular invasion, they are associated with nodal metastasis and poor prognosis. So on this basis, these lamina propria invasives are subdivided into PT1 B because of the poor prognostic features of these tumors, of these features. Coming on to T2, there are published evidences that tumors restricted to the corpus spongiosum they do well better than those invading the corpus cavernosum. Based on that, it was called PT2. So this is a couple of examples for these lesions. This is a transverse whole mount section. We can see the tumor invading into the corpus spongiosum, and we can see this is the urethra here, and a gross a picture of the same lesion. And a transverse section of a penis where the tumor is involving the foreskin and portion of the glands and the sulcus, and thus limited by the tunica albuginea. So a high power view of this invasive focus in this picture here. So PT3 tumor invades corpus cavernosum, and this includes the tunica albuginea. They may be with or without urethral invasion. In this, this is an example of the PT3 tumor where there is the tumor involvement of the almost replacing the entire corpus spongiosum and then going into the um, uh, corpus cavernosa. So this is the H&E resection showing a tumor infiltrating into the corpus spongiosum, going beyond the tunica albuginea into the corpus cavernosum. Finally, PT4 tumors invade adjacent structures, for example, scrotum, prostate, and pubic bone. So this is an example of a PT4 tumor where the tumor ulcerated the whole skin and then penile area and then involving the scrotal skin. After the PT staging, now coming on to the end staging, in AJCC 8 edition, the end staging system, patient up to 2 unilateral inguinal lymph node metastases are considered N1, and 3 or more than 3 unilateral or bilateral inguinal lymph node metastases are considered PN2. Both should not have any extranodal extension. This change is clinically important because initially it was only single lymph node in N1, and now it's up to 2. So this changes, it has a clinical consequence. Patients with N1 may not need additional adjuvant therapy after inguinal lymph node dissection. So it saves quite a few patients who have just who have up to 2 distinct lymph node. Initially, it was just 1. So these are based on multiple studies, one of which initially proposed this the lymph node modified lymph node staging was this by Lee et al., which shows a clear separation of N1 and N2 in this in their proposed method. There are still problems with PT2 and PT3 tumors. Kearns et al. Found in a retrospective in an evaluation of about 902 patients that there is no difference in lymph node staging between stage PT2 and PT3 based on corpus spongiosum or corpus cavernosum involvement. And which has been supported by a few other studies, some of which I mentioned here. Also, lymphovascular invasion has also been shown to be a significant separator of both stage of PT2 and PT3. These are the studies which have shown the lymphovascular invasion for these separation. So few authors have proposed a modified staging system for PT2 and PT3. Lee et al. Proposed a modified staging system based on LVI, dividing PT2 and PT3 based on the lymphovascular invasion. PT2 is now tumor invading corpus spongiosum and or cavernosa and or urethra without lymphovascular invasion, and PT3 with lymphovascular invasion. In their study, there was no significant difference in cancer-specific survival between PT2 and PT3 in both training cohort and validation cohort according to the AJCC 8 edition. And while it is significant in the proposed system, here is the Kaplan-Meier curve representing the validation cohort from their study. You can see the small separation, and this is the proposed system. Another proposed modified staging system is by Sali et al. Using lymphovascular invasion, perineural invasion, and tumor grade, like we substage PT1A tumors. So PT2 tumors, according to them, their proposal is tumor invading corpus spongiosum or cavernosum without LVI or perineural invasion and is not grade 3. And PT3 is which shows one of the poor prognostic features, which is not in PT2. The new staging system shows a statistically significant correlation between for nodal metastasis, while it did not show for the AJCC 8 edition. Similarly, only the proposed model significantly impact disease-free survival, as depicted in this Kaplan-Meier curve. This is the AJCC 8 edition, and this is a new proposed system. Subsequently, the same authors compared their proposed staging system with their external validation cohort of 281 cases. In their study, they compared AJCC the 7, 8, and the proposed system. And they found that the AJCC 8 edition and the proposed staging system shows a significant correlation with nodal metastasis. However, there is better strength of association with the new staging system. The disease-free survival was significant for all three systems. However, for cancer-specific survival and overall survival is only the AJCC 8 edition and the new proposed staging system are clinically are significant statistically. On ROC curve analysis, the proposed staging had the highest area under the curve, which is depicted in this present slide, where a blue line depicts the proposed staging system. The above two proposed staging system were compared with the AJCC 8 edition by Kakoti et al. In a group of 54 patients. They found that PT2 and PT3 by all staging systems shows statistical significance difference in their survival outcome. With penile cancer as shown here in this three Kaplan-Meier curve. However, they found that the SALI staging system to be more efficacious for predicting lymph node metastasis, and the Lee staging system has a slightly more efficient in predicting the overall survival. So these are the some of the proposed staging system for PT2 and PT3. So, since the shaft of the tumor has a somewhat different anatomy, as I discussed initially, this portion of the shaft has the dartos fascia and the buccal fascia. The dartos fascia or muscle is as I mentioned, it's a discontinuous layer of smooth muscle fibers, while the buccal fascia is composed of loose fibrovascular tissue. So Taken et al. Proposed a staging system for the shaft of the penis based on these anatomy. They proposed that for PT1 tumor limited to the dermis or superficial dartos fascia, which is just limited here, while PT2 is to be limited to the tumors extending to the dips and buccal fascia. They did not. They left the PT3 and PT as same. So in their study, in a small group of 6 patients with tumor limited to the shaft, 3 presented with nodal mets. Of this 3 cases, 2 of the cases would have been PT1 according to AJCC 8 edition, while in the according to the proposed system, it would have been PT2. So this study needs to be validated in a bigger cohort. So these are the proposed staging systems. So in summary, knowledge of the anatomy and awareness of different surgical procedure is critical for appropriate staging of penile tumors. Reporting of resection margin is very important in all surgical specimens. Staging according to AJCC 8 edition is based on the depth of invasion with subdivision of PT1 tumors based on perineural or lymphovascular invasion and histologic grade. Urethral involvement does not affect staging according to AJCC 8 edition, and more recent studies suggest alterations in PT2 and PT3 stages as well, based on LVI, perineural invasion, and tumor grade. Thank you.
Thank you, Judy. That was a very comprehensive run through of a difficult topic. And there are already some questions that have come up. We're actually going to hold the questions till the end. So we'll have all of our 3 speakers, and then we'll have a brief time for questions available at the end. If you want to ask a question, there is a Q&A button at the bottom of your screen. So if you can click on that and then type the question into the Q&A chat there, and we'll address the ones we can get to. I can already see that there was a few questions from Judy's talk, so we might not be able to get to them all, but we'll endeavour to get to the ones that are asked most frequently. So we'll hear back from Judy again at the end, when we have time for questions.
Thank you.
So now we're going to move on to Dr. Jasram Dillon, who is a senior member of the Moffitt Cancer Centre, where she is the section head of genitourinary pathology. She went to medical school and did her pathology residency in India, and then moved to the US, where she repeated her pathology residency and did a GU fellowship training at MD Anderson Cancer Centre. She's the program director of the combined GU Gynae Fellowship Program at the Moffitt Cancer Centre, and she's the author of more than 80 peer-reviewed publications and 11 book chapters. She's going to be speaking to us about the spectrum of precursor and non-invasive penile lesions. Take it away, please.
Thank you, Fiona, for the kind introduction, and thank you for providing me with this opportunity. Let's see. Let me start. Can you see my screen now?
You're on presenter view.
Okay. So I'm going to talk about a spectrum of precursor and non-invasive penile lesions. And I'll start with condyloma acuminatum, just to compare the histological findings of low risk HPV compared to the high risk HPV. Now, condyloma acuminatum is a benign disease. It's a non-neoplastic lesion, which is caused by low risk HPV human papilloma viruses, commonly referred as genital warts. These appear as on clinical examination can show a pink or tan brown exophytic cauliflower-like growths. They are seen on penile glands, foreskin, and skin, common in young men, and are mostly caused by HPV low risk types 6 and 11. Coming on to the pathogenesis, majority of the condylomas are about 75% are caused by HPV 6 and HPV 11. And interestingly, 15% of these are also caused by high-risk HPV subtypes. Now,
Jasmine, can I just,
yes.
you're actually on presenter view. Can you change it to the full screen?
If you go to display settings in the top left.
Settings.
And swap. Thank you.
Okay. So the low-risk HPV viruses are not actively involved in carcinogenesis because their oncoproteins, because their genome does not integrate with the host DNA. They are not actively involved in carcinogenesis as their oncoproteins do not cause significant downregulation of retinoblastoma, P53 and P16 tumor suppressive pathways, which is done by high-risk HPV subtypes, as we'll see later. And this is the histology of condylomas. They are characterized by acanthosis and papillomatosis, and they have well-demarked bulbous end. They may have prominent fibrovascular cores. The surface is characterized by hyperkeratosis and parakeratosis, and there is no atypia or dysplastic features seen within the epithelium, apart from the coilocytic atypia, which is seen in the superficial layers of the squamous epithelium. Rarely we can have flat or inverted patterns. This is the high power view. You can see normal maturation of the squamous epithelium. It's only in the surface epithelium that you have coilocytic atypia and hyperkeratosis and parakeratosis. At times, these lesions present as giant condylomas, also called Buschke-Lowenstein tumor. commonly where there is large confluence of condyloma, which replaces the normal tissue, and they can grow up to 20 centimeters in size. These are usually benign. However, malignant transformation can be associated, especially if co-infected with high-risk HPV subtypes. Certain host factors like immunodeficiencies are commonly associated with development of these huge lesions. Again, they are characterized by papillomatosis and acanthosis, hyperkeratosis, and parakeratosis. These are the high power views. You can see a normal maturation of squamous epithelium with keratinocytes in the superficial layer. Occasional dyskeratotic cells may be seen. And here you can see keratinocytes, which have enlarged nuclei. Some of them may be binucleated, multinucleated with nuclear contour irregularity and perinuclear halos. Moving on to the penile intraepithelial neoplasia, these are defined as premalignant lesions of the penile squamous cell carcinoma. These are characterized by dysplastic squamous epithelium, but with an intact basement membrane. Median age of presentation is around 59 years of age, and WHO divides them into two subtypes. One is a PEIN that are HPV associated. They have different patterns associated with them. And the second subtype are the HPV independent, which are called differentiated PEINs. There is a different geographic distribution for these two subtypes, which was very nicely shown in a study by Soskin et al., where they compared the PEINs in Paraguay and France, and found that French population, majority of their PEINs were HPV associated, compared to the Paraguayan population, where a majority of the PEIN found was differentiated PEIN, which is HPV independent. Now, PEINs are not to be graded. We're not going to call them high grade, low grade. They are all considered high grade. We just call them penile intraepithelial neoplasias. WHO does not recommend using terminologies like penile carcinoma in situ, bovine disease, or erythroplasia of Kara. These are only called penile intraepithelial neoplasias, and we can further subclassify them whether they are HPV associated or HPV independent. A few words about HPV associated penile intraepithelial neoplasia. These are rare lesions. However, among PEIN, they constitute majority of cases. So majority of PEIN that we are going to see are HPV associated. 25% of these progress to invasive cancer. And if the lesion is present on glands and is associated with high-risk HPV 16 and 18, the malignant potential is reported up to 30%. However, the malignant potential drops drastically if the lesion is present on shaft, where the invasive potential is only 5%. There are different patterns associated with HPV-associated PEINs. These are basaloid, warty. It can be a mixture of basaloid and warty called the mixed pattern, and the rare patterns, which are the clear cell pattern, spindle cell pattern, and the pagetoid pattern. The basaloid pattern is the most common, and it is caused by HPV 16 and 18 in majority of the cases. A few words about the pathogenesis of HPV-associated PEINs. The hallmark is the integration of the viral genome into the host genome, which leads to secretion of oncoproteins E6 and E7. E7 combines with the retinoblastoma protein, and it causes inhibition in its action. Once the activity of retinoblastoma is inhibited, the cells progress through the cell cycle and go on to proliferate. Inhibition of retinoblastoma also leads to upregulation of P16. Hence, all the HPV-associated PEINs have upregulation of P16, and P16 is also a surrogate marker for HPV infection. E6 combines with P53 protein and causes degradation of the protein, and hence inhibits apoptosis and causes cells to proliferate. So there is also unrestricted telomerase activity along with evasion of apoptosis and dysregulation of retinoblastoma, P53 and P16 tumor suppressor pathways are important in the pathogenesis of HPV-associated PEINs, which can some of them can progress to invasion. HPV-associated PEINs usually present as a lesion, which can be an abnormal growth or it can be an ulcerative lesion. It can present as sharply defined plaques with a velvety erythematous appearance, especially on the glands. It is also seen in uncircumscribed patients who have phimotic foreskins. The shaft lesions are raised or flat with irregular borders. They can be white or crusty, scaly, or scaly. Moving on to the basaloid pattern of the HPV-associated PEIN, these are the most common pattern, and it is usually associated with a single high-risk HPV subtype, which is HPV-16 in 70% of the cases. And the epithelium is acanthotic, and rarely a pebbly formation with fibrovascular cores may be evident. And if we look at the histology, we see the entire epithelium. It's acanthotic and it is replaced by monotonous proliferation of these immature looking epithelial cells, which have a high N-to-C ratio and little to moderate amount of cytoplasm. The surface shows hyperkeratosis and parakeratosis. Usually when we do P16, these are diffusely positive for P16 immunohistochemical stain. On the right is the picture of HPV, high-risk HPV RNA-ish. There is focal nuclear and cytoplasmic dot-like positivity in these cells. Here, the positivity is not that robust, whereas we have cases where the positivity is more robust, as you can see, nuclear and cytoplasmic dot-like positivity of high-risk HPV RNA-ish. This indicates, this actually identifies the E6 and E7 mRNA of the virus and is an indicator of active replication of the virus within the host cells. The second subtype of PEIN HPV associated is the Warty pattern. Warty pattern is the pattern which has largest number of HPV genotypes. Up to 11 have been isolated, and it's also a pattern where largest number of low-risk HPV genotypes have been isolated. HPV 56 is the most frequent high-risk HPV genotype, which is isolated in this lesion. It is characterized by acanthotic epithelium with a spiky surface. There's hyperkeratosis and parakeratosis. The epithelium may have pleomorphic cells with coilocytic atypia present in the superficial layers, and numerous mitotic figures may be scattered throughout. This is high power view where you see dysplastic epithelial cells with lots of mitotic figures from a base to almost to the top of the epithelium. And this is a microphotograph of the more superficial layers of Warty type PIN, where there is hyperkeratosis, parakeratosis, and you can see some coilocytic atypia in the superficial cell layers. If we do P16 immunohistochemical staining, it has a very characteristic pattern. It strongly highlights the basal and the suprabasal cell layer, whereas the keratin and the keratin layer does not stain positive for P16. And these are also positive for high-risk HPV-ish. The third common pattern is the mixed pattern, which shows combined features of Warty and basaloid patterns. The basaloid cells, which are the small immature cells with a high N-to-C ratio, are seen at the base of the epithelium, and the more differentiated cells, including some coilocytes, are seen on the surface. Again, the surface may show hyperkeratosis and parakeratosis. This is high power view. You can see the basal cell layers, which show more basaloid cells, which appear more blue as they have a higher N-to-C ratio. And as the cells go on the surface, they have more cytoplasm, and they have kind of features of both basaloid and warty subtypes. And then the pagetoid pattern of HPV-PIN is a rare subtype. It mimics the extramammary Paget disease. It is characterized by these large irregular epithelioid cells in a pagetoid manner within the squamous epithelium. We have to distinguish these from extramedullary Paget disease, from melanomas, and pagetoid spread of other cancers like urothelial carcinoma. And this is again a microphotograph where you can see these single atypical cells spread within the squamous epithelium. If you do P16, these cells are positive for P16 and are also positive for high-risk HPV-ish. That's coming on to the immunoprofile and of the HPV-associated PIN. So all of these show diffuse block positivity for immunohistochemical stain P16. Ki67 will show positivity up to the suprabasal cell layers. P53 is usually negative, but can also be positive in some of the cases. These cases are positive for a high-risk HPV-ish and are negative for low-risk HPV-ish. PCR has identified many viruses. Among them, high-risk HPV-16 is the most common. Moving on to the HPV-independent PEINs, these are the precursor or the pre-malignant lesions of the penile squamous cell cancer. These are characterized by dysplastic squamous epithelium, primarily of the basal and parabasal cells within an otherwise very well differentiated epithelium with an intact basement membrane. This is more frequent in countries which have higher incidence of penile cancer, commonly seen in older uncircumcised patients compared to the HPV-associated PEIN. It is commonly seen on the inner surface of foreskin and presents as a white plaque and is a precursor of different subtypes of squamous cell cancers, frequently associated with lichen sclerosis. Now, differentiated PIN, again, it is not recommended to use terminologies like squamous cell carcinoma in situ or to grade them as low-grade dysplasia or high-grade dysplasia or call them PIN 1, 2, 3. They are not graded. They are all considered high-grade. Hence, we just call them differentiated or HPV-independent PEINs. A few words on the pathogenesis. For HPV-independent pathogenesis, TERT-P mutations have been more frequently associated compared to the HPV-associated squamous cell cancers. And the inactivation, there is direct inactivation of the P16 tumor suppressor genes. Hence, there is low expression or no expression of P16 in HPV-independent PEINs. P53 mutations are present in majority of these. Okay. And moving on to the histopathology, these lesions are characterized by epithelial hyperplasia, parakeratosis, hyperkeratosis, dyskeratotic keratin pearls, and spongiosis may be present within the epithelium. The atypical cells are predominantly present at the base or suprabasal cell layer. There is retained squamous maturation, which is seen in the upper layers of the epithelium. There are different, depending on the spectrum of the atypia, they are classified as hyperplasia-like, which have minimal atypia, which is present at the basal cell layer. The atypia is so subtle in these cases that you have a hard time differentiating these from benign hyperplasia. And in these conditions, when there is differential diagnosis, we do take help of immunohistochemical stains, where Ki67 and P53 stains are helpful. In benign hyperplasia, Ki67 is either negative or it may show scattered basal positivity, whereas if this is a hyperplasia like PEIN, the positivity is seen in a more continuous pattern in basal and suprabasal cell layer. P53 will be negative in hyperplasia, and that is the positivity will be restricted to the basal cell layer. Whereas in hyperplasia like PEIN that are associated with P53 mutations, either there is complete absence of staining or the staining is present in basal to suprabasal cell layer. P16 will be negative in both of these cases. This is another example of differentiated PIN where the atypia is extremely subtle. You see these enlarged nuclei of the epithelial cells present predominantly at the basal cell layer. There is hyperkeratosis and hypergranulosis. Plus, there is some degree of spongiosis present here, which is seen as this little cleft between the dermis and this epithelium, and prominent intracellular junctions within the squamous cells. And this is again diagram photographs of Ki67 stain and the P53 stain. This is differentiated PIN, hyperplastic-like. And this is Ki67 immunohistochemical stain, where you can see that it marks the basal and suprabasal cell in a more extensive manner compared to hyperplasia only. And this is a P50 immunohistochemical stain, which shows complete absence of staining in differentiated PIN. Classic pattern is characterized by more atypia, where the atypia is present in the basal as well as suprabasal cell layer. At least lower 2/3 of the epithelium are involved, and the superficial layer shows more maturation in the background. Pleomorphic subtype, where markedly pleomorphic cells are spanning the entire thickness or more than 2/3 thickness of the epithelium. Again, hypergranulosis may be present. Rete ridges may show elongation and intercommunication. Lichen sclerosis may be present in the background. PEINs are treated, are excised. Their recurrence rate is high if the margin is positive. Rate of progression to invasive cancer varies from 2 to 30%. And it is important to remember that HPV-associated PEIN and differentiated PEIN associated with lichen sclerosis may remain latent for many years. They can be treated with topical chemotherapy, laser ablation, circumcision, Mohs micrographic surgery, or glands resurfacing. A few words about EMPD. I'm running out of time. So these are rare intradermal adenocarcinomas, can present either as primary tumor or can be secondary to another cancer like prostate cancer, urothelial cancer, colorectal, or cutaneous. In origin, we do not know the precursor cell yet. Usually, these lesions present as erythematous scaly skin lesion, which covers large area. It is patient presents with pruritus, and these are characterized by pallid cells, which occur in clusters within the epidermis. Important to remember, these can also be invasive. Up to 10 to 20% of EMPDs can be invasive, and they can metastasize to regional or distant lymph nodes or to bone. Positive for CK7, GATA3, ER, and GCDFP15, which are important in the diagnosis, usually treated with wide local excision. Even with this, the recurrence rate can be as high as 40%. And that was the last of my slides, and thank you for your time.
Right, thank you. Very well timed. So now we'll move on to our third and last speaker, who is Santosh Menon. He's professor and pathologist at Tata Memorial Centre, Mumbai, which is one of Asia's largest tertiary cancer centres. He's an active member of the Male and Female GU Disease Management Group with specialist interest in GU cancers. And he's been part of the editorial board of the 5th series of the WHO classification of the Blue Book series for the male genitourinary system. So he's going to be talking on penile squamous carcinoma. Thank you, Santosh.
Yeah, thank you, Fiona, and thank you, Samson, and thank you, Gups, for having me here. Am I audible? Well, yes. Okay, so I'll just share my screen. Is it visible?
Yes.
Okay. So thank you once again for the GUPS committee for having me here, and Judy and Just Raymond have made my talk a little easier because they have shown fantastic gross pictures and precursor lesions. So my job is to describe and discuss a little about the morphological features and subtypes of penile squamous carcinomas, and how it fits into the clinical team, and how is it part of an MDT. That's the important thing which I'm going to cover. I begin with New Year wishes, although it's a little late for Christmas, but this is New Year. I have no conflicts of interest. Most of the images are from my own department, provided by my clinical colleagues, the clinical images, and the patient confidentiality is maintained in these. So just to begin, India is a country where we worship the phallus. So this is the known as Shivling, which is the phallus of Lord Shiva. I'm not a proponent of Hindu religion, but this is what happens in India. It's a huge country, large population. There are temples of this idol all over our country. But when it comes to the phallus cancers, the penile cancers, these are the cancers which we see in our day-to-day practice. Huge cancers destroying and distorting the penile anatomy completely. We see very few of completely precursor kind of lesions in our practice, being a tertiary referral center. So this you can see that these are the type of cancers which we see in our practice. So that's unfortunate because it's a social stigma to have something on your reproductive organ, and that's why these patients come to medical attention at a very, very late stage when the tumors are very advanced. A peak under workload in 2019, we had about 165 cases, out of which about 80 was resected. And just in 2023, we are collating our data. We had about 255 cases of penile biopsies, resections, including 106 resected specimens at our hospital. We have already discussed that the vast majority of malignant tumors of the penis are squamous carcinomas, most commonly seen in the glands, and others are the coronal sulcus and the foreskin. Most of the previous classification schemes were morphology based, but in 2022 and 2016 to be precise, the precursor as well as invasive squamous carcinomas have been classified based on HPV. And this is the latest WHO 2022, a picture from the online edition of 2022 edition. You can clearly see that invasive epithelial tumors, just like the precursor lesions, are divided into HPV associated squamous cell carcinomas and HPV independent squamous cell carcinomas. So this is another blow up of the table. You can see that invasive carcinomas, the HPV associated, has a lot of subtypes like the basaloid, warty, clear cell lymphopithelioid. We'll see some pictures of these cases. And the commoner ones are the HPV independent, which is the usual type of squamous carcinoma, the keratinizing type, with some subtype or variant kind of like pseudohypoplastic and pseudogonal, which are extremely rare again. Verrucous carcinoma, papillary are also under the HPV independent. And these are basically classified based on their morphologies as well as by employing P16 immunostain. So if you don't have P16 for evaluation, you may end up calling us just as a squamous cell carcinoma, not otherwise specified types. So some questions which come into our minds when we talk of squamous carcinoma penis is, how do we diagnose HPV associated versus HPV independent? Is morphology enough to classify? Are there ancillary tests and markers which we really need to do all the time to classify? And are they really necessary? Is it important to exercise this classification to distinguish these two? Are these morphological subtypes prognostically relevant? How does HPV figure in this? And what are the issues and variations in subtyping of penile cancer? So in this lecture, we'll try to address these. So we move on to the HPV independent ones. The most common one is the squamous cell carcinoma usual type. 50 to 60% of the lesions are found on the glands. Is the most common type, and it arises most frequently in the 6th and 7th decades of life. We have very young cancers also in our country, basically because of the huge population and the referral biases. And about 45 to 65% of penile cancers are of this subtype. It is generally a keratinizing carcinoma rising from the mucosal aspects, which is seen here. There is a variable spectrum of carcinomas ranging from well differentiated to poorly differentiated. That comes into the grading of the spectrum of this usual squamous carcinomas. And these may have varied patterns like a superficial spreading, vertical type of growth, verruciform, which is not very uncommon, and multicentric kind of growth patterns. Some pictures, every one of you must have seen these keratinizing squamous carcinomas, which are invading the subepithelial tissue lamina and the deeper tissues of the penis. Judy has very nicely described this. So these are generally very easily recognized. They can have this intracellular keratinization. They can form good keratin pearls, and these are pretty much very easily recognized. You may have this very, very hyperplastic, verruciform looking tumor which can grow, but the keratinization, striking keratinization of the usual squamous carcinoma is very easily visible. The usual squamous type carcinoma is negative. You can have this patchy kind of staining here and there, which is interpreted as negative for P16. And that's how this is under the HPV independent classification. So some more pictures to show you the patchy kind of staining which may occur, which is generally not a nuclear kind of staining, which is important to say something, call something as positive. Again, more pictures to show that these can have trabecular pattern, they can have single cell pattern of infiltration into the underlying, so they may be associated with lot of inflammation in the underlying tissue, and that can sometimes obscure these tumors. If you can note in this picture, this is a squamous carcinoma usual type with very early kind of invasion into in these island kind of pattern. You can see the corpus spongiosa here with a lot of adipose tissue in this elderly male. You can imagine if there is a punch biopsy from this, you may not be able to see the invasive front in a small punch biopsy because of the superficial tumor is all keratotic and has this kind of pattern. So we must keep these in mind. Obviously, there is a clinical person involved, and you have to talk with your clinician, communicate with your clinician when you get biopsies, difficult biopsies of penile cancers. And so these are generally pictures from resection where it becomes more easy to diagnose these kind of cancers. So these are high power pictures to show the invasive focus and the invasive front. Again, usual type of squamous carcinomas, different kind of varieties. Some may have this kind of very, very basket weave kind of keratin patterns. Then there's more poorly differentiated kind of usual squamous carcinoma. They show some keratinization, but look at the anaplasia here. So when the anaplasia they start becoming more blue, and that's the time when you start getting confused with a basaloid kind of pattern, basaloid kind of squamous carcinoma, when there is a lot of anaplastic and blue looking cells in these usual. And that's when you really want to employ your P16. And if you have access to HPV testing, you should do in those patients. Again, this is a verruciform kind of usual squamous carcinoma, and this is a completely endophytic kind of squamous carcinoma usual type with a lot of keratinization. The prognosis is based on the grade and the stage of these tumors, which override the actual histology. So it's the grading and the staging of the tumors which is more important and clinically more relevant. The clinician is more interested in those kinds rather than exact subtyping in such cases. Verrucous carcinoma, very important not to miss this cancer. It can affect the glands and also extend to coronal sulcus. Most of them are seen there. They account for less than 10% of all penile cancers. And it is very important to understand that these have this bulbous kind of elephant feet kind of broad pushing pattern of infiltration. They are very, very straight kind of these kind of papillae with not very well-formed fibrovascular cores. They're rather fused at places, but the broad elephant feet kind of invasive focus are the most important thing, or the front with the lamina propria where you should recognize them and call it. The importance of recognizing these verrucous carcinomas is that these patients don't need an inguinal dissection, and they don't even need a sentinel node kind of surgical procedure, because they do not metastasize. If you have truly diagnosed a verrucous carcinoma, I know it may seem very easy on picture, but this is one of the most difficult diagnoses sometimes where we encounter in a day-to-day practice when we are looking at these tumors. So these are some pictures to show verrucous kind of. You can see this is a complete whole scan of the slide. You can see that this has got broad pushing fronts into them. Sometimes they may be associated with small invasive focus, where it is called a microinvasive focus of a verrucous carcinoma. You can see these tires, and you can see the broad pushing fronts. Another picture to show these very, very broad looking fronts with a lot of keratinization between these broad fronts on the superficial aspect of these tumors. So it's important to note. A kind of a subtype within a subtype is a carcinoma cuniculatum, which is also a very, very subtype of you can take a type of verrucous cancer where there are burrows of these very well differentiated squamous islands which are going deep into deeper tissues. They are pushing into it, but actually not invading and destroying them. So the word comes from the word cuniculus, which is rabbit burrows. So this is somehow this is one of the gross pictures of a cuniculatum carcinoma. They are like burrows going deep into the tissue, burrowing into the deeper compartments, anatomical compartments, but they are so well differentiated, and none of the tumors which have been diagnosed till now have metastasized. So this is a picture of cuniculatum. You can see that this is the surface epithelium, and then you have this tumor which is burrowing deep down into the deeper tissues of the glands. Here, the differentiation of the cells is they are very, very well differentiated. You may have these kind of broken kind of superficial cells which are falling into this. More pictures to show how a carcinoma cuniculatum looks like. You can see how broad these fronts are and how the broad bases, similar to verrucous carcinoma, these are there, but then they are deep down burrowing into the anatomical compartments of the penile tissues. So despite the deep penetration and not infiltration, what we want to call it, none of the reported cases have shown ground metastasis of this. Another type is the pseudo-hyperplastic carcinoma, again, a type of usual squamous, typically confined to the foreskin. So important to know that when you have a foreskin excision and you are looking, you must keep this in mind that usual squamous carcinomas occur there, but pseudo-hyperplastic is something also which can occur, and it usually associated with lichen sclerosis or a very lichenoid kind of inflammation. So this is like this. You can see here at the bottom of the image, you have the corpus cavernosa with the tunica albuginea and the glands at the lower end. And at the upper end, it is on the this tumor is on the aspect of the undersurface of the prepuce. It has got this very, very pseudo-hyperplastic kind of appearance with large islands and a lot of lichenoid kind of inflammation, which is still present here. So these tumors occur. This is not a very clear picture, but again, to show that the foreskin, you have this very pseudo-hyperplastic kind of tumor, and maybe there is an extension of these tumor to form a grade 1 usual squamous carcinoma in this picture. The dangerous one, histological subtype, is the sarcomatoid squamous carcinoma, very fast growing tumor. Most of the patients already have either a nodal metastasis or a distal metastasis in the lung. And whatever cases we have seen, none of them have mostly survived beyond 2 or 3 years in these patients, because most of the time they are presenting with systemic recurrences and systemic metastasis early in this. When it comes to histopathology of sarcomatoid squamous carcinoma, they generally can resemble a fibrosarcoma, leiomyosarcoma. Sometimes they may have a fascicular and a storiform pattern, and that may create a little problem for you. But always keep in mind that more than a sarcoma of a penis, there is always a possibility that this is a sarcomatoid squamous carcinoma. We can employ markers like high molecular weight keratin and P40, and they help in the diagnosis. So these are pictures of sarcomatoid carcinoma. They can have a lot of inflammation in between, especially neutrophilic infiltration in some of the cases, and they may start resembling actually angiosarcomatous kind of pattern in these tumors. Mind you, keratins may not be very strong positive in this. They may be focal, and you may have to repeat your keratin stain, EMA stains, and other stains on several slides before you can actually demonstrate the thing. The other HPV independent subtype is the papillary squamous carcinoma. It's usually located in the glands, or the other compartments may also be involved. It accounts to 5 to 15% of penile cancers, and the patients again generally present in 6th or 7th decade. The exophytic tumors, they can be mimic grossly warty type kind of tumors, and even on microscopy they can resemble warty tumors, so warty carcinomas. And that's important that we understand the histology of this, and obviously employ P16 and HPV in difficult cases to differentiate this as an HPV independent carcinomas. So this is how it looks. I've put in some pictures from Sanchez et al. Where they have made these diagrams of how papillary carcinoma can look like. So they have these multiple fibrovascular cores and branched fibrovascular cores within this ragged kind of infiltrating borders, and this is how they look, the very, very well formed fibrovascular cores, and they are generally pretty well differentiated, covered by this very well differentiated kind of squamous, and they are P16 negative because they are HPV independent, and the prognosis of papillary squamous carcinoma is generally supposed to be good. Very important again, subtype is the pseudoglandular carcinoma. Patients are younger, but they are higher grade tumors, and we have to be careful when we diagnose this. The histology is generally characterized by prominent acantholysis. So you have these squamous islands, which looks like the usual subtype of squamous, but then there is prominent acantholysis, which gives rise to the pseudoglandular spaces. The tumors have honeycomb kind of appearance like this, and you can see that the cells are falling into these lumen-like spaces because of acantholysis, and they can look away. The important thing is these are deeply invasive tumors, pseudoglandular carcinomas, and so they are high stage tumors at presentation, and many of them would present with regional metastasis and can even cause mortality of the patients if diagnosed late in the days. So that ends the HPV independent carcinomas. Going to HPV related carcinomas, the most important ones are the basaloid, warty, and the combination of these two, which already Gisraman has highlighted that these arise on a background of HPV associated or related PEINs. And so These are generally solid kind of tumors. They do not exophytic. The basaloid ones are non-exophytic tumoral masses. They are solid, firm lesions. They involve the glands and corpus spongiosum, and they may be sometimes may be excessive papillary when they are known as papillary basaloid squamous carcinomas. The important point clinically relevant are that many of these basaloid are deeply invasive. They have vascular and perineural invasion, which are again prognostically important, especially the presence of LVS. I've seen this. They show strong block positivity of P16, and sometimes they may be so blue under the microscope that you may start thinking of neuroendocrine carcinoma or a metastasis from somewhere else, because they may or may not show too many keratinization. Although in center of these islands generally show some abrupt keratinization in these. So these are basaloid carcinomas, solid fleshy looking masses, not very papillary looking. Again, basaloid carcinoma looking very fleshy. Again, picture to show that these central necrotic areas might be seen amongst these island of blue looking cells. This is a very large scanned slide which shows this large tumor, and even at low power you can see that the tumor is very, very blue in color, and the central necrotic spaces, the comedonecrosis pattern is very, very prominent in these basaloid tumors. Again, very blue looking tumors. You can have some abrupt keratinization in this at the center, and the presence of. So if you're struggling with that, look at the periphery of the lesion. You may find HPV associated PI in these very basaloid looking at this. And these show strong P16 block positivity, both nuclear and cytoplasmic, which is to be considered positive in these tumors. Again, some more pictures to show the basaloid and the P16. The next is the warty squamous carcinoma, which is again HPV associated. Again, they can occur anywhere from the glans, coronal sulcus, or the foreskin. But these are more cauliflower-like and exophytic, and on gross, sometimes it's very difficult to distinguish them from verrucous tumors or other tumors. Warty carcinomas the important thing to distinguish from other condylomatous kind of tumor is that there are frankly atypical coilocytes throughout the tumor. So that's important. It is a very verruciform kind of a neoplasm, and it might be difficult if it's in a pure form. But many of these warty carcinomas are admixed with basaloid carcinomas, because both of them are HPV associated. And in our setting, when we see these large tumors, many of the surface features are of a warty carcinoma, but the invasive front is many times looking very basaloid. So that's the important understanding of warty, that pure warty can be difficult to distinguish from a verruciform, other verruciform lesions, but in a combined setting, you can find. So this is a nice warty kind of look carcinoma, where there are irregular, ragged kind of these papillae which are growing, and then you have invasive focus in this. This is a warty basaloid. You can clearly see the superficial aspect of the tumor shows very, very pleomorphic coilocytes, whereas the deeper invasive aspect of the tumor is more basaloid and blue looking. So these are a combination. They can occur in different combination proportions throughout the tumor. You can see this warty basaloid again showing the basaloid aspect on the left hand aspect, and the very pleomorphic coilocytes which you see on the superficial aspect of the tumors. Higher power to show these coilocytes, binucleate forms, and this. Again, some pictures to show the warty and basaloid looking tumors, very warty on the surface and basaloid on invasive front. And these are diffusely and strongly positive for P16, especially the basaloid type, which is basaloid one, which is strongly and diffusely positive. When you have a papillary configuration of these basaloid, they are known as papillary basaloid type. You can have this lot of basaloid cells on a papillary kind of a stem, and then you can label them as papillary basaloid squamous carcinomas. Basaloid are aggressive neoplasms. They are deeply invasive tumors associated with lymph node metastasis, and they also have a potential to have cancer-related mortality. So it's important to put this in your report when you are reporting penile cancers, because the clinician generally understands at least these kind of thing in this. The other type of HPV-associated cancers are the lymphoepithelioma-like cancer. The name itself is pretty much self-explanatory, but the tumor generally has a syncytial growth pattern with sheets and nests of tumor cells with a dense lymphoplasmacytic infiltrate. If you do a P16, if you do a keratin, you will find those tumor cells lying in between these lymphoplasmacytic infiltrate. And sometimes you may need to employ P40 and P16 to recognize these. So this is a lymphoepithelial-like carcinoma with a lot of lymphocytes scattered throughout the tumor, and they have a syncytial pattern. The borders of the tumor are not very clearly visible. The tumor cells are not clearly visible. Again, the stage of this tumor is important. Prognostic factor, not very much studied tumor. Clear cell, again, a very, very rare composed of large clear cells with intracytoplasmic VES positive diastase resistant material. I'll just couple of pictures I'll show. They are highly aggressive tumors. Most of them would have inguinal lymph node metastasis. So this is a squamous carcinoma, which is showing a lot of clear cell change, which is happening there. Almost 90-80% of this tumor was totally clear cell. In fact, there were certain features of admixture of a lot of eosinophils in this tumor, and we were wondering whether this is a clear cell carcinoma along with the medullary kind of, because both of them are supposedly HPV associated tumors. I think I will skip this quickly because I just want to talk a little about the relevance of these tumors. I am running short of time. So this is your final histopathology report. You would put all these points, including the type, subtype, the tumor site, size, anatomical level of invasion. Those are the grading of the tumor. All this information which we are giving to the clinician is important in their management, further management of especially the inguinal lymph node. So inguinal lymph node in a penectomy, after a penectomy is the most important question which is asked by the clinician, whether to address that or not. And these are the 3 disease specific survival when you have nodal positivity in these tumors. So it's extremely important that we gross the tumor properly in a penectomy specimen and give all those points on histopathology so that they can address the node, because nodal involvement really portends a poor outcome in this. If you look at the NCCN guidance, this is from 2022, but even the 24 has similar thing. Any grade 2 tumor and T1 PT1 tumor more than that would be a candidate for inguinal nodal surgery. And that's an important thing which we as pathologists should also be very clearly aware. The grading is a prognostic factor. We can know that there are a lot of studies which say, and grading has its own issues. I will not go into the details of these things. It can be heterogeneous. The tumor can be very heterogeneous. We know that well. These are pictures to show that the same tumor can have very well differentiated grade 1 areas and grade 2 areas. Then you have anatomical levels of invasion, which are part of the staging system. This has its own issues. When we see this is a whole mount, you can see the tumor, which is looking very keratinized and differentiated, is going into the tunica albuginea, infiltrating superficially the tunica albuginea in this. So patterns of invasion, multiple LVS and PNI, these are all prognostic important. So where does it leave the histological subtype? There are so many other prognostic factors. So people have studied and put them into low risk, intermediate risk, and high risk groups. There is not a standard practice, but there is an understanding that grade 1 verrucous, papillary, pseudohyperplastic, and cuniculatum are a low risk variety or a low risk subtype. The intermediate group includes the mixed and warty, and the high risk includes all the rest, which is the high risk usual basaloid, warty basaloid. And they have studied that this low risk versus the intermediate risk versus the high risk group of tumors have got different chances and have independent prediction of lymph node metastasis. The EU has a little different category. They put the warty in the low risk compared to the intermediate risk in many other systems, but otherwise it's more or less similar. If you look at this nomogram and look at the points, nowhere in this nomogram there is the histological subtype. So the point is, you can put this in your report. You have to educate your clinical people what a pseudoglandular means, what a pseudohyperplastic means, and those will help them learn, and those will help them understand and integrate your histological value of histological subtyping into this. But currently, many of these things don't have. Obviously, there is low level of inter-observer concordance in assessing histological subtypes. We have to employ a lot of ancillary tests like P16, IHC, the role of P53 and HPV testing, not only for diagnostic, but the question of prognosis is also coming up. And we know that although in other cancers, HPV is now well established as a prognostic factor, in penile cancers, there is still a controversy in these. There are several studies. I'll not go into the details. The testing of HPV is also a problem, not available everywhere. But now it is being understood that HPV-associated penile cancers may have a better disease-free survival. So that's the current understanding, and we have to go ahead with this and do studies together. So when we are fraught with these kind of problematic papillary and verruciform lesions, we have to definitely employ P16 and if possible HPV to distinguish. A very poorly differentiated cancer, basaloid, non-basaloid, we have to do P16 and HPV testing in these cases. So I'll quickly skip this and go to this. So this is P16 employed in this tumor, which was looking very much like a HPV associated usual type of cancer, but turned out to be basaloid. P53 has already been shown by Disraman. I will not show this. This is a usual squamous carcinoma, which is very strongly and diffusely positive for P53. And this is a warty basaloid carcinoma, which has got this patchy kind of staining of P53. So sometimes you may end up doing these stains and they may aid, but they are not 100% to be believed. You have to believe in your morphology, look at other features to aid in the clinical management. So we come back to the last slide. So these were the questions we asked ourselves at the beginning of this lecture. So I'll say most of the subtypes can be recognized in morphology, site and differentiation. However, it is strongly recommended that as a group, we all start employing P16 regularly on all cases. The question that is it really necessary exercise? I think there is mounting evidence that HPV-associated penile cancers may have better outcome and DFS, especially when treated with radiotherapy. So we need to really start subtyping these tumors. And are these morphological subtypes prognostically relevant, and how is it? So although the grade stage and LVSI have proven relevance in the prognosis, I think we have to impress upon the clinician that certain subtypes like tuniculatum, verrucous, they have a very, very good outcome. Whereas the pseudoglandular ones, the basaloid ones, we need to keep on putting this in their report so that they are also familiar with this term more and more, and they understand what the subtype and their meaning is. I think the issues and variations in subtyping will remain till we study large and get together to do these studies as a whole. I would really like to thank Dr. Kuvila. I think he's the father of penile cancer, and I think lots we have learned all from him. And there are other people. I especially want to thank my students, Dr. Akash and Ashish, and other students who have been in teachers in my learning in these things, and also my department colleagues, and definitely my urology clinical team who have helped in the learning and understanding of penile cancer. Thank you very much.
Thank you, Santosh. That was amazing. Very good and thorough handling of the topic. Now, just as our other two speakers come back online and unmute, I'd really like to say thank you for the whole program. It's been fantastic, and I think this will be a very valuable resource that we can come back to. So, of course, this talk, all the talks have been recorded and will be available subsequently. And I certainly will be re-listening to these again because these penile tumors, we see them infrequently often, and sometimes, you know, it's good to have somewhere you can go to and actually put your hand on the information that you need that's relevant and up to date. We've only got about 10 minutes for questions, and there's actually been quite a number of questions that have come in, so we won't be able to answer all of them, unfortunately. But I thought we might start with Judy. With your talk, there were a few questions that came up about tunica albuginea and staging. Could you just cover that again for us?
So in the AJCC 8th edition, involvement of tunica albuginea is part of the stage PT3. So the reasoning, like wherever the studies that have been performed, corpus spongiosum and corpus cavernosum involvement studies that have I've come across, they've included tunica albuginea as part of cavernosum. The idea is that if the tumor can their reasoning is that if the tumor can infiltrate a thick tunica albuginea, that is they are biologically more aggressive. That's why they are considered part of PT3. That's the reasoning. But then nowadays, as I've shown there are many problems with dividing staging based on just these. So there are other factors. But as of now, tunica involvement would be PT3, just without going through and through. Like if it's invaded through, not just touching, but invaded. Yeah. Does that answer the question?
I think it does. That's very helpful. Thank you. And so, Jasraman, you were talking about P53, and there's been a couple of questions about the P53 staining patterns. Could you just explain that a little bit more, and maybe others might like to talk about their institutions and how they deal with that as well?
Yes, with P53 immunohistochemical staining, what we practice in our institute is to call it positive. Either it has to be very strongly positive, you know, lighting up like a Christmas tree, for example, what Santosh showed in one of his microphotographs, or there has to be complete absence. Now, staining which is focal, limited to basal or maybe few suprabasal cells, very faint, we tend not to call these positive.
And maybe the others?
Yeah, even in our practice, we don't employ P53 very commonly, not in all cases. So maybe in about 10% cases where we are struggling with something and we really wanting to distinguish between something and we think it's dependent. And so the interpretation of P53 is fraught with a lot of difficulties. And like Jasraman said, if it's just lights up all the cells as strongly, or if it's a null type kind of mutant, then only we really can rely on that. Otherwise, the staining can really throw you off track.
In MSK also, we don't usually employ P53 on a routine basis. Then we try to, the only thing is like try to divide between HPV or non-HPV. We do mRNA and P16. But then we don't get as many cases as Tata Memorial. And also, I noticed one of the papers that it's from the vulvar. They correlated P50 expression with, but I don't think we have used that in penile tumors.
And Judy, you showed some very beautiful full mount sections, and that's really, yeah, I appreciate how great they looked. And I was very envious because we don't have whole mounts in my practice. So I think maybe for you and for Santosh, how do you differentiate between corpus spongiosum and corpus corpora cavernosum histologically when you don't have a whole mount and you're not quite too sure where you are?
That's I don't know. I mean, you can help me in this. Corpus cavernosum, there's always issue with it. If you see it in isolation, there's always issue with this. But the general idea is that corpus cavernosum, they are more muscularized and less elastic tissue, while the corpus cavernosum, spongiosum has less, is more collagenized and less of smooth muscle. So it's the amount of a smooth muscle. Is there anything you want to add, Santosh?
Yeah, so in spongiosum, generally you will have more of fibrous tissue between the vessels, and the vas vessels are more gaping, they are more spread out. Compared to cavernosum, where the muscle fibers are more wispy and more intercommunicating kind of fibers, which you see in this. They can have very difficult times when you struggle with these two, especially if you have a section which has no landmarks in it, actually. And with age also, there are certain changes, like you have fatty infiltration and adipose tissue in spongiosum, cavernosum. Those are roots of spread of these tumors, and there have been studies on that present. So that can also add a lot of confusion to these. But in general, if you have a good section of the glands and it's labeled well and all, we would be able to recognize the anatomical landmarks.
I think part of the problem is we get the specimens fixed, and they're often a bit distorted by the time the trainees actually go to cut them up. And I know I often get called up to have a look at the macroscopic because they're actually having trouble with the landmarks. And, sometimes they kind of look a bit like a pretzel, and trying to sort of straighten things out and work out where they are. Actually, one of the early questions, Jasraman, was how do you know if you've actually got a penectomy or a partial penectomy? Sometimes they can be quite small and they're actually called a penectomy. How do you differentiate?
The question is directed to me or just Raman?
Oh, sorry, Judy. Yes, sorry.
Okay, so I mean, it is more, I think, a surgical procedure, not like something that we can easily say on the gross specimen. So I think that would be more to do with the surgical procedure, what the surgeon is sending.
Thank you. So sorry, the next one was for Jasraman. This is about so we're having a bit of a discussion about sometimes it's hard to differentiate, between various things. You were talking about wart with dysplasia from PN. How do you make that distinguishment between the two things, because there are quite, a bit of overlap?
This is an excellent question. Warts, how often do they have dysplasia? Extremely, extremely rare. But let's presume they have dysplasia. A wart with dysplasia versus PIN, HPV associated, how do I distinguish? It's going to be extremely challenging, and I'm going to rely on positivity. If the positivity is for high-risk HPV, I will default calling it PEIN. If the positivity is for low-risk HPV, I would prefer calling it a wart with dysplasia.
And just as a follow-up, have you noticed anything so far in your practice with the effects of the HPV vaccine?
That's a very good question. PEINs, how often do we come, which are not associated with invasive cancer? Again, extremely, extremely rare. And for this, if I refer back to the literature, there are conflicting reports. There are reports that, yes, it has its effect on preventing the genital warts. But with PEINs, I think we are still in the midst of getting an answer.
And what about in regards to invasive tumors? Santosh or Judy?
Yeah, I think about HPV vaccine and invasive tumors.
Mm.
In our country, HPV vaccinations is yet to take off on a big scale, actually. So we are still waking up to giving HPV vaccination to large population. So we would take another 10 years to see any effects of these HPV vaccines, actually.
Exactly, because HPV vaccination is more common amongst youngsters, right?
Yes.
And HPV is a disease when a man is in their 40s, 50s, or 70s rather.
Yes.
So I
And
think
also, I think it's very new, nascent for penile tumors now, but most of the studies I think are based on the cervical and the
Oh, that's
vulvar
fine.
literatures. Yeah, so I don't think we have enough data for penile tumors.
And in Australia, we're actually vaccinating boys now for HPV. Are you doing boys in your contexts as well, or just girls?
boys are also getting vaccinated.
Boys are also getting vaccines.
Okay, I think we're almost to time. We didn't cover all the questions, unfortunately, and there were some very, very good questions in there. So I'm sorry about that, but we do need to end up because we've gone for an hour and a half. So this is a bit of a longer session. I think Samson was going to put up a slide about the next session that will be available. So Santosh and myself are on the organising committee for the education committee for GUPS, and we do have a program that will be running this year with quite a range of topics, and the next one will be available next month.
Thank you, Fiona and Santosh, for moderating, and of course to Judy, Jasmine, and Santosh for your excellent presentations. Wanted to draw everyone's attention, and will continue through GUPS membership emails as well as social media posts. Following up on our penile cancer pathology session, we'll have a session on adrenal neoplasia on Thursday, February 8th. The details are here and forthcoming to you, featuring Drs. Ozga Mete and Peter Sadow, moderated by Drs. Maria Tretiakova and Shonak Gupta. Have a wonderful day or night, everyone.
Thank you.
Thank you, everyone.
Thank you all.
Everyone. Thank you. Thank you. See you. Thank you.
We leave? Yeah, I guess so.
Bye. Bye-bye. Bye-bye. Good day.
Bye.
Thank you, Samson.
Night.
Bye-bye. Bye-bye. Good night.